The Small Rural Hospital Transition Project, or SHRT for short, assists rural hospitals in transitioning to value-based care and alternative payment models, as well as prepare hospitals for population health management. In May of 2019, SHRT convened a panel of experts in population health strategies for the Rural Care Coordination and Population Health Management Summit. This video showcases some of the panelists as they speak about the key initiatives that leaders and providers can take to further develop a local infrastructure to manage population health in the future. Find the full summit findings report and care management guide on the ruralcenter.org website.
Well, the healthcare industry is currently under pretty dramatic transformation, and that transformation is largely caused by a change in the payment for healthcare in general. So we're now paying for population health, wellness, and value. And in the past, we paid for procedures. It's a dramatic shift, and I think it's going to be great for the American people and great for the healthcare providers as well.
It's scary because 2015 they said we had 54 billion Medicare recipients, and in 2030 we're going to have 80 million Medicare beneficiaries. Where is that money going to come from? Working in a rural hospital, we simply cannot afford to take any more losses.
It's really looking at what can we build on slowly, and take it one day at a time. And that's what we need to remember. Just start looking at what you have, and build upon your strengths, and then identify your weaknesses and start to resolve them. One of the things that I did a few years back was a readiness assessment. Are you ready to even move into population health? And I think that really builds your foundation.
If you've made the decision or commitment that the world's changing, then get your board and get your providers on board with the fact that the world's changing. And for primary care providers, it's really an easy sell because they get to practice medicine really the way they always wanted to. Because they can see that there might be a light at the end of the tunnel where they're not focusing on RVUs and volume and trying to bring them in and out. And then I think in those primary care settings, how do you build a team within each setting so that not only are you looking at managing those patients when they're accessing care in the office or following up on a visit, but how do you begin to reach out to them in the community?
One of the key challenges is going to be making this transition from our traditional payment system over to this new population health payment system. And part of the problem is, in many cases, we may have Medicare, for example, which is now paying for population health management and value. And meanwhile, we have other types of pay-for-procedure payments, but we have to start thinking from a population health standpoint, and we need to start designing processes and procedures that are going to really enable us to make that shift. So it's like staying financially stable as long as we can here, and then positioning ourselves in our strategies and in our community to play this very important role into the future. And that will then make us valuable to bigger healthcare systems, to our community itself, and to the payers as well. We should be looking to strong telehealth connections. So we need to build that telehealth infrastructure, but also looking for the capability to provide services directly into the homes as we're keeping people in their homes as long as possible, as we're keeping people in our community as long as possible. And all of that fits within the infrastructure of the new payment systems. We're seeing our rural ACOs actually outperform the urban ACOs. We're able to change quicker. We're primary care based, and we're seeing substantial, really impressive improvements in quality scores and reductions in cost as well.
Provider of choice is your operational efficiencies. What are you doing to improve the way you operate, the way you outreach, but then also the way you function on a day-to-day basis? How are you improving your outpatient services? If we know our patients are no longer going to be in those inpatient beds as much or as often, and our length of stays are reducing, what are we doing to improve our outpatient services? And that's all part of your operational efficiencies. And then, that just builds into your financial resources as well.
Nothing can prepare you to join an ACO until you've done that, and then you have to really start working with your population. You have to start getting them in ahead of time, scheduling wellness visits, doing those screenings that will help you identify potential issues that they're going to have. And by doing that, you're going to reduce the cost because they're not going to have to go to specialties, and they're not going to have surgeries and things that cost taxpayers a lot of money. They also need to, become more preventive. I would suggest that you start small. Find one illness that is prevalent in your community and your population, and what is one thing you can focus on to improve that condition. So if it's diabetes, maybe you start doing diabetic foot exams or your eye exams, or if it's obesity, maybe you start checking the BMI and setting care plans and goals for the patients to improve on. One small step can really help in getting you prepared for population health. The clinic and the hospital have partnered together so that when patients are discharged, we're calling them, making sure, are you taking your medication? Are you able to get to your physical therapy? Are you doing everything that you need to be doing so that you're not coming back to our hospital and being readmitted? I think population is about seeing the patients at the right time. It's getting ahead of the issue before they have an issue, and by doing this, we can improve the quality of their life.
We're going to see our rural hospitals become more of community health centers, and we're going to see a whole lot more telehealth as well. So the object will be not to bring patients into the hospital, but basically to keep them well, provide outpatient services, to do chronic illness management, and very importantly, to do prevention and wellness. So we could be talking about healthier food, better housing, better social conditions, etc.
We found that instead of our volume and our revenue going down, the more we try to keep people out of the hospital, it seems like the more market we attract. So that says to me that people actually like to be engaged in managing their own health care. We continue to see that trying to manage people proactively and engage them is the right thing to do, and we're doing it at the right time. We're not finding that it's hitting our bottom line negatively. In the future, the best day financially for this organization is going to be when there isn't one patient in the hospital. And what that means is that we changed how we finance healthcare to support and incentivize that and we build in controls, quality controls, so that you're not just withholding care. You're still providing it and people can access it appropriately, but you have converted to a model where you're really committed to keeping people out.
We need to be able to call people together to talk about some issues like behavioral health, opioid addiction, diabetes, and some of these other diseases. And kind of in that regard, we can enlist community partners to help us, and on a long-range basis, to kind of form a community care coalition that can actually work to keep people healthier.
A number of activities that we've engaged in are all pointed at how do we improve the health of the community, what are the services that we should be offering, making sure that they're at the caliber that is recognized by the community as safe and not being, a Band-Aid station, and beginning to really wrap their arms around that thing that they have in their community, which is really special because not every community has one, and that's called a hospital.